Okay. As opposed to an ugly MI, we're going to talk about acute MI. By definition, we're talking about an ischemic myocardial tissue that necroses, so it ends up dying, and that's secondary to a alteration in blood flow to that part of the myocardium. Most of the time, it's a thrombic event. In other words, it's a clot that forms. They can occur at rest. They can occur with exercise. They can, the pathophysiology there is that you have an occlusion of one or more of the coronary arteries, and eventually it leads to reduction in oxygen delivery and death. The degree to which blood pressure or cardiac output is affected is related to how much heart muscle mass is lost, as well as what portion of the heart is damaged. The progression that exists is initially an ischemic event happens where the lack of blood flow leads to chest pain being developed. If that is persisted, injury to the actual muscle will happen. Injury and ischemia are still reversible. It's not until you get to necrosis that you end up having death of the tissue and loss of muscle mass. So here we have an ischemic area and an injury area and an infarcted area. Ischemia is definitely reversible. Injury may or may not be reversible, but again, an infarction is not. Lots of risk factors that cannot be, some that cannot be changed, and by the way, it should be gender probably rather than sex. We don't want to give anybody the wrong idea there, because you can't alter, never mind. Certain genetic characteristics put you at a high risk or higher risk. As you age, you obviously do, and the other risk factors that can be altered, you've seen pretty obvious ones that are there. The term time is muscle is important because you want to do everything you can to minimize the amount of tissue that is lost, because that's going to end up impacting how well you can be managed. And there is a time frame in which drugs like those thrombolytics we talked about, the TPA, can be administered. And if you wait too long, you blow that window and you are no longer a candidate for using them. 95% of the patients have what are called prodromal symptoms, which means that they have some kind of symptoms that should tip them off that there is a potential problem there. Women have different presentation of pain than men. First of all, women are stronger, more stoic. They don't show the pain as much. They discount it a lot, and a lot of it's not the crushing chest pain that men have. It's more of a uncomfortable feeling. Often they're epigastric in nature, so they think they're just having,
epigastric problems.
Yeah, I feel like I have this belch I can't get rid of.
So the pain's probably the same, but you just handle it better?
I don't know if it's that necessarily, but it definitely manifests itself differently. Okay,
Jaw pain is common.
Yep. In fact, I don't have that one on there, do I? Chest pain radiating up to the jaw. There have been cases of where patients thought they had a toothache, went to the dentist, and they had an MI. But certainly, the more of those symptoms you have, the worse the situation is. We diagnose a myocardial infarction by a combination of not only a history and physical, so having these clues pointed out to us, I'm having chest pain, I'm feeling nauseated, etc., but also looking at some specific cardiac enzymes and the need to get a 12-lead ECG. Okay. Most MIs that we talk about are on the left ventricle or involve the left ventricle. However, they can affect the right side also. The management of a patient with a right ventricular infarction is totally different than the management for somebody on the left side. We're going to be able to look at these 12-lead EKG to determine the site of the infarct by looking at things like T-wave inversion, ST elevation, and the development of a prominent Q-wave, which is a marker that is there forever. So once you have a inferior wall MI, your ECG tracing will always show the presence of a Q-wave in the inferior leads. You guys have seen this before, right? How to do an EKG? Liars. Yeah, you should know where the placement for the various electrodes are in the process. And what we generate are basically 12 different views that are there. And you can see that V1 a little, V2 a little more, V3 definite, V4 definite. You start seeing in a ST elevations in those leads, which are pointing us towards an anterior, almost an anterolateral area. And by the way, when we talk about, if you think, well, if you think, if this is my heart, you think of it as the left ventricle as a box. The top of the box is the atria, so we don't really concern ourselves with that. But there is a anterior wall, a lateral wall, a septal wall, an inferior wall, and actually a posterior wall. Okay? So each of these areas can be identified by looking at a specific spot on the on the 12-lead EKG. Did Mary talk about that? A little bit? Glad we got that one on tape, don't you? That was Dana. The former president. Wow, wonderful. All right. So as you go through this process of ischemia to injury to infarction, you see alterations in the tracing that are present. First off, there's a T-wave inversion. Then that ST elevation climbs and the T-wave actually begins to flip back over. And then finally you develop a significant Q-wave when you actually have an infarction present. Actually, yeah, I do have it then. Some of the ACLS, advanced cardiac life support, management for acute coronary syndrome, one of the changes that they did, and I still have a problem with this, but so long as our saturation is greater than 94%, we don't administer oxygen therapy. I just find that very odd. If I have somebody coming in with crushing chest pain, none at all. Yeah, that's weird. Their premise is that you have a high enough oxygen that it should be sufficing. You don't need to add any more. But certainly you're going to do, IV monitor process. Look at a 12-lead EKG, screen for thrombolytic therapy. Again, those patients who have active bleeding going on from, for whatever reason, you might not want to give thrombolytic therapy. There's some relative contraindications to it. But it's those enzymes that are important to look at in the process. MONA greets all MI patients. There's actually some twist to that, but M stands for morphine, O for oxygen, N for nitroglycerin, A for aspirin. So kind of easy way to remember that. And then your thrombolytic agent should be considered. The ideal is door to drug in 30 minutes. Okay. So you want to get as quick as possible this person evaluated for whether or not they're a candidate for TPA and go from there. Complications of the MI can be multiple. You can end up having areas of the heart, because they're underperfused, become irritable, so you have these dysrhythmias happening, either atrial, ventricular, wherever. You can end up, if the MI is affecting an area of the heart where the vessel involved feeds the conduction area, the AV node, for instance, or the SA node, you can end up having a process where a heart block develops. And anterior MIs, that front wall, because that's the one that's involved with pumping function, big anterior MIs are manifested by rapid drops in blood pressure. So you end up having a really bad hypotension and low cardiac output states with an anterior. And this is just kind of looking at where we've come over the years. If you look at the number of deaths that you have per 100,000, first open heart was 1954, and you can see that as we've developed better and better strategies, including coronary angioplasty, where we go into with coronary arteries and using a balloon push the plaque back against the wall, and putting in stents to be able to keep that area perfused, we've dramatically reduced the death from cardiac events. So we're getting better at managing it for sure, where COP is kind of going the opposite direction, unfortunately. Okay, so that's acute MI. Congestive heart failure basically is the inability of the heart to pump blood to meet the metabolic demands of the body. The left ventricle cannot adequately pump blood because it can't. How's that? I use the analogy of a cart and horse, okay? If I'm picture in your mind, you have this horse that's pulling this cart, and the cart becomes too full, and the horse can no longer pull it. It becomes too difficult for that horse to move it. What are our options? One, we can go ahead and take some of the load away. Make the load lighter. Okay then. We can apply the little bit of the whip to the horse to get a little more oomph out of him, or we can choose a different road that's much more flat. Okay, it's not as much to work that the horse has to pull uphill on. Well, relieving the load means reducing preload. How do I reduce preload? Give them a diuretic, something that's going to remove fluid in the process. I can give them more whip. I can make their contractility stronger by giving them drugs that improve contractility. Digoxin, inotropic support. I can also change the road to make it easier to pull that load, and that would be reducing afterload. Giving something that'll a beta blocker or something else to reduce the systemic resistance. Okay, so all of them kind of play in together as far as how we manage them. Severe cases of congestive heart failure we actually call cardiogenic shock. It's a special type of loss of blood pressure so significant that you end up having inadequate oxygen delivery. When we have the left ventricle unable to pump out blood, well, it's still coming from the right side of the heart through the lungs, so it just can't go any further, and it backs up. Backs up into the pulmonary artery, pulmonary vein, pulmonary venules, eventually back to the pulmonary capillary. As the capillary pressures rise, fluid moves out of the vascular space, through the interstitial space, into the alveoli, and as it goes back across that process, you end up having bubbles forming, which is what we're going to call the fulminant or foaming pulmonary edema in the process, and that's what it kind of looks like. Okay, and as you can, it's a very ineffective way to promote gas exchange. Let me go back here and talk about Starlings Law of capillary. Come on.
Okay. You may have, how many people know what Starling's Law of the capillary is? Wait till I, Emily. All right. If this is my interstitial space and this is my vascular space, okay? So this is the pulmonary capillary. This is the interstitium between that and the alveolus. Got it? There is a balance that is created between how much fluid, if this is the, let's say this is the venous side, this is the arterial side. Okay, you follow me? So this is coming from the right side of the heart, going back to the left side of the heart. Fair? There's 5 things that control how much fluid is maintained in the vascular space. And the first one is the capillary hydrostatic pressure. Hydrostatic pressures push out. So they push fluid out of the vascular space into the interstitial space. Okay? At the same time, there's an interstitial hydrostatic pressure which pushes right back. So far, so good? So these push out. There's also an osmotic, also use the word oncotic. I'm going to use them interchangeably, even though technically they're not, but you'll see them kind of used interchangeably. O-N-C, oncotic, that pull in. And guess what? There's an interstitial pressure, osmotic pressure that pulls fluid in. So there's this movement of fluid in one direction or the other depending upon where those values are at. Listen closely, rise in capillary hydrostatic pressure promotes the movement of fluid from the vascular space into the interstitial space. When we have congestive heart failure, we said that the left ventricle can't pump the blood up, so it backs into the left atria, backs into the pulmonary vein, backs into the pulmonary venules, and eventually backs all the way up here where this value then rises. Think of this as that pulmonary capillary wedge pressure we talked about. As that pressure rises, it pushes fluid out of the vascular space into the interstitial space and eventually into the alveolus. Okay? So that's the pathophysiology associated with congestive heart failure and pulmonary edema. Now, under normal conditions, the amount of push and pull that exists leads to a small amount of fluid left in the interstitial space by the time the whole thing is done with, and the lymphatics drain that off. That's the function of lymphatics. This is basically determined by large proteins, specifically albumin. Okay? So somebody who's malnourished, who doesn't have a high albumin level, they don't have the ability to pull that fluid back into the vascular space. It stays in the interstitial space and can lead to the same kind of pulmonary edema that you would see from congestive heart failure. The origin of it is totally different. The origin is because they don't have enough protein. But the bottom line is exactly the same. So
If you have a COPD patient who is wasting and exit, is that a term? That'll make that worse?
potentially,
He doesn't have the
potentially he could end up having a pulmonary edema type picture that's non-cardiogenic. Yes. Now there's 1, 2, 3, 4 factors there, right? There's also a 5th, because life would not be nice only having 4.
There's got to be one just to throw a monkey wrench in there. And I'm just going to call this capillary permeability. If you think about it, this fluid is moving in and out of the capillary through small pores, through small holes. Okay? If I make that hose really leaky, more fluid is going to move out. Does that make sense? Okay. We're going to come across a thing called ARDS. We've talked about it previously, this acute respiratory distress syndrome. Their problem is that fifth factor. They got a leaky hose. So they end up in a pulmonary edema type picture, but it's non-cardiogenic. It's not caused by the heart muscle being too weak. It's caused by this other factor. That was painful.
You could say it's vessel velocity.
Yeah. Never seen this before? Is that a true statement? Or if you did, you sure don't remember it?
I saw it. It was quite like this.
It wasn't as elaborate as I do it, of course. My fine artwork.
Makes it memorable.
I probably should use yellow, shouldn't I? That red's kind of hard to see. All right. So that's the net effect that you end up having. The capillaries, fluid moving out of the capillary, flooding the alveoli, leading to these bubbles. Okay. This is the fifth factor. These are the ones that are non-cardiogenic pulmonary edema. Picture looks exactly the same. If you look at chest X-ray, I shouldn't say that. The net effect is exactly the same. You end up having an inability to effectively exchange gases because I got all this fluid in there. But there's a lot of other things that can cause it where that permeability of the capillary just changes. We talked about ARDS being one of them. Smoke inhalation we'll find would be another one. Drowning could be another. Near drowning can be another one as we go along with these. Yeah.
So if you have a congestive heart failure.
That's cardiogenic.
Yes, then you will have pulmonary edema. So they go inside.
You may, depending upon the severity. If it's just a mild case, you may not end up having massive pulmonary edema. You may have areas where some of the alveoli are being flooded, but it's not to the extent that we see it all over. You guys went through auscultation, right? Listening to breath sounds? Woo! A lot of fun. When you evaluate somebody, you have them sitting in the upright position, and you evaluate for the presence of adventitious sounds, right? When you develop congestive heart failure, what ends up happening is initially it's a very mild form and there's not a lot of alterations, but you'll hear some bibasilar crackles. Okay, so you hear some adventitious crackles in the bases. As the disease progresses, we can actually quantify how severe it is by to what extent those crackles move up the chest. So when it's a third of the way up, or is it 2/3 of the way up, or is it throughout all the lung fields? That's showing the progression of mild to moderate to severe to very severe. Does that help? Okay. So what signs and symptoms would these people exhibit? Well, obviously they're going to be short of breath. Sitting there, orthopnic, have to be in an upright position. This dyspnea can often occur at nighttime. Again, crackles are going to be their primary lung sound we're going to see. The sputum is frothy, can be white or pink tinged. As that moves across, it actually maintains a little bit of a bloody color. Weight gain is common, especially when you're talking about ankle size. Dull percussion note, because the alveoli are flooded, they're not going to transmit air sounds, and you'll have a lot of fremitus if you were to feel them in that sense. With a cardiogenic pulmonary edema, the key part is that you have, well, first of all, you have bilateral whiteout. You have bilateral, I'm going to call fluffy infiltrates, but basically you end up having areas of the lung where they're very white, okay, meaning there's a lot of fluid.
In addition, your cardiac to thoracic ratio is greater than 50%. So if you look at the width of the heart, it's occupying more than half the size of their chest. You may end up having pleural effusions, and we'll talk about what transudates versus exudates means. But again, this would be an example where you have a loss of a costophrenic angle. Because there's fluid accumulating there, you don't have that well-defined costophrenic angle. There's something called curly B lines. I don't know if there's curly C lines or not, or curly A lines, but there are curly B lines. And they're basically just some linear whiteness that exists. But it's that radiopaque white chest x-ray that you end up seeing. So here we see massive heart width, and not as white as I would expect it. It's kind of an overexposed film, but there. Then there's the non-cardiogenic, the other end of the pulmonary edema spectrum that isn't caused by the heart. And here again, you would not see an enlarged heart nor effusions in the process. Blood gases, again, can be anything from a mild case of hypoxemia with some alveolar hyperventilation. As the disease progresses, the hypoxemia becomes worse and worse, and you end up having eventually acute ventilatory failure. At the same time, because you're hypoxemic, you're also then going to an anaerobic metabolism, that whole Krebs cycle, and you end up having an acidemia secondary to that. So you end up with really a mixed acidosis developing. If you were to do pulmonary function tests, which you never would, but you would find that you have lung volumes that are reduced. So this is a restrictive disease process. Okay? You also would have a loss of diffusing capacity because that alveolar capillary distance is becoming wider because the interstitial space has been made wider. If you were to measure with a pulmonary artery catheter, you would see that they would have pulmonary hypertension and an increase in wedge pressure, again, in the cardiogenic one at least. Reduction in ability to pump blood out because the heart muscle can't keep up. And if you are into that left axis deviation, this is an example of where you would have one because the size of the left ventricle has become larger because of all the excess blood that's accumulating there, then you end up having a leftward shift. Ejection fraction, remember, is that percentage of what's in the left ventricle prior to ejection, and then what percentage of that is pumped out. Normally it's about 65 to 70%, but in heart failure you end up having a reduction in the ejection fraction, so there's not effective pumping going on. And we can measure that through echoes typically. So, what's the goal? Reduce preload. Give them some diuretics. We lighten the cart. Decrease the afterload. Give them a vasodilator to make it so it's easier to pump against. Find an easier road, and then use the whip. Increase the contractility. So, oxygen therapy is appropriate for these people? I would say so. Put them in a position where they're easy to breathe. We're definitely going to give them some diuretics to reduce the preload. Morphine's a wonderful drug for these people simply because it does a couple different things. One, it increases venous capacitance, meaning it keeps blood peripherally, not allowing it to come back. It also relaxes the patient. Patients have a hard time breathing, so they get anxious, which makes it worse. So give them a little bit of morphine, give them some happy medicine, and they don't feel as bad about it. Increase contractility through the use of inotropic support. And one of the therapies that is proved to be very, very beneficial in acute pulmonary edema to prevent them from needing to be mechanically ventilated is something called BiPAP, or more appropriately, non-invasive ventilation. Using a face mask and a positive pressure generator, I create 2 levels of pressure. That's why it's called BiPAP. Bi-level positive airway pressure. And by altering the pressure in the circuitry, I'm in essence ventilating. But what it is not so much an acute care ventilator as an augmentation for their spontaneous breathing. So their ability to generate a decent tidal volume spontaneously, they're getting tired out. by allowing this machine to basically boost their tidal volume, I take away some of that work of breathing and I can effectively ventilate until those other things can kick in. So acute pulmonary edema has had great success in this group of patients because it's a bridge. I don't have to intubate them. I can keep them non-invasively supported until the diuretics work, until the inotropic support works, and then wean it off. Okay? And that's it. I'll stop and pick up on the latter two later. Questions? We all know where we're going tomorrow, hopefully? God willing? Making fun of me, girl?